Next, we have a vitreoretinal surgeon par excellence from our part of the country to talk to us on when a surgical intervention is needed in diabetic retinopathy. Inviting Dr. Mahesh G from Giridhar Eye Institute for the same.
Just a few points before that, I just added to Dr. Lot of PGs will be here. So whatever Dr. Danya has said, the complete thing is covered. Nowadays, we don't two things on DME. One, DME is not an emergency treatment. It does not require an emergency treatment like a AMD, where if you wait for 1 month, it will cause scarring. That is one thing I always tell. You can go slowly. So most of us will give PRN based monthly injections, no loading dose of 5 or anything like that. This is practical thing I am telling. Some of you are medical retina people treating. So give one injection, after 1 month see, then second injection, like that, based on that. Number two, if the vision is very good, 6.9 or 6.6, you can wait with metabolic control. So we don't aggressively treat pure DME with very good vision. This is not my take, this is DRCR net recommendation. Number three, there is nothing called grid laser now. There is nothing called grid laser now. Practically, none of the retina people give grid laser because the grid laser has been replaced by anti-VEGF injection. So focal laser and injections. So these are the two things. Focal laser to the leaking microaneurysm seen in fluorescein angiogram. So these are three things in DME, practical points. Now, my talk is when do we need our VR surgeon to save us? This us, I presume, is medical retina people. Okay, medical retina people, not general ophthalmology. General ophthalmologist has another, they have to detect the disease and refer when needed. So this is medical retina people. So medical retina persons are needed in India because of the enormous number of diabetic retinopathy in India. So 90% cases can be managed by medical retina people. Like, so that is what I am telling. Us means medical retina specialist. More than, if you get a fresh diabetic retinopathy, there is 1 out of 3 chance that it is going to worsen with your treatment. That is for sure. So that you have to tell. Okay, this is this also is old ETDRS that also shows it prevents vision loss only in 50 to 70%. So if you start treatment, 1 out of 3 will worsen. So I always tell the patient, communication is very important. You have to tell that there is a chance of 70% chance that you are likely to remain like this, but 1/3 of people will worsen. And put it on the patient's head that because you have a diabetes which cannot be cured. So this 1/3 will go, they are going to come and tell you that you treated and my vision reduced. So every 1 out of 3 is going to tell you this. So VR surgeons are needed. So how I counsel, I will show my collection of cases. So because in my case, I do laser, I do surgery. So that is no problem. So I tell, if it is not working, I will do surgery. That is okay. But this is not possible in a medical retina. Like DME not responding to treatment. You give 1 injection, 2 injection, nothing is happening. Look at the OCT. There is a epiretinal membrane or a taut hyaloid. How much ever injection you give, it is not going to worsen, improve. So that is that biomarker or epiretinal taut hyaloid in the OCT. That will tell you even if you inject. So these cases will require vitreoretinal surgery at a later date depending on the visual acuity. So this is not going to respond. Now this is another case of vitreomacular traction. How much ever, just see the OCT little carefully, see whether there is any taut hyaloid or membranes which will prevent reduction of, and never treat based on central macular thickness. Again and again I tell in every forum, don't treat that central macular thickness. That is not the thing. The configuration of the retina and the findings like this in biomarkers are more important than central macular. So this is post-operatively you get. So these sort of cases, be careful before keeping on injecting. 1 or 2 injections, they are likely to worsen also. Then there is something called recalcitrant macular edema. You inject 2-3 times, fine. Before treatment was left side. After treatment, you can see the edema is little less, but hard oxalate has increased, right? So this sort of recalcitrant, after 3 injections, if the vision and edema is not reducing, probably you have to reconsider. Either switch a drug or refer to vitreoretinal surgeon for vitrectomy. Many of these cases, recalcitrant edema likely to improve with vitrectomy. Taut hyaloid. This is very dangerous situation. You see white area, not blood. that is fibrous tissue, they are likely to worsen with laser. So preoperative and postoperative, these cases will require surgical intervention. Then this is another case, free macular fibrosis. This is called pre-macular fibrosis, that white area. So these cases, all not only DME, PDR cases. So this case, if you give, what will happen if you give pan-retinal photocoagulation? The vascular element will become more fibrosed. So the fibrosis increases, macula will become more bad, vision gradually reduces. So if such a finding is a premacular fibrosis, VR surgeon may be needed. So this is preoperative and postoperative. Now this is another case. Already bleed is there, hard oxalates and pre-retinal bleed. Most probably this will end up with surgery. So probably medical retina person can give little laser and 1 month later see and then refer. Already tell the patient this will require surgery. We will try to give little laser and see after 1 month. So this is another thing. Now clearing the media, that is another area where VR surgeon is required, like asteroid, recurrent vitreous hemorrhage, but you don't see anything. It is very difficult to give laser also. Angiogram is a very useful modality in this. Cataract, vitreous hemorrhage and DME. Lot of patients come like this. There is cataract and DME is there and maybe little vitreous hemorrhage. These cases, ideal method is either you do cataract surgery, then refer it to VR surgeon for vitreous, or single stage you can do whole thing together. So these are all cases where VR surgeon may be needed in this. So this patient underwent cataract surgery with vitrectomy and additional laser, and this lower one right side is the final follow-up. So they do well with systematic treatment. So post phaco IOL vitrectomy, this is another case, left eye, in the OCT there is a taut hyaloid. So post surgery, even though the hard oxalates are the lower one is a post-operative 6/12 post phaco IOL vitrectomy. So these are combined cases which we do to improve the vision. Then scene 4 is PDR likely to worsen. You give laser, then he starts bleeding. So these cases, especially if you see a bad big new cells in fluorescein angiogram, be careful. You have to take Mungur jamium before starting treatment. So that is important, because patient will not understand the theory, all these percentages. So this is a important case that I always show. There is a huge NVD actually, and 6/6 vision. And these are really, after PRP, 1 week later patient came with the right side picture, 1 week later. So very difficult to deal with these cases. So you have to talk to the patient initially. And this is another pre-treatment is left side. Post PRP, you can see that blood has become white, that is fibrosis. Neovascular element has become fibrotic. So this patient gradually lost vision, and then we did surgery. Crunch phenomenon is another thing. Many of us give excessive laser in heavy burns, and immediately 6/6 has become hand movements in 1 month. Crunch phenomenon, the whole thing contracts and detaches. This requires immediate surgery. So these are not easy cases. So crunch phenomenon. And there are cases like this. It is going to worsen, fibrous tissue and new vessels. And so these cases you have to initially itself take the opinion of VR surgeon. And extremely ischemic retina, all these cases. And taut hyaloid fibrosis, premacular fibrosis. This is another case that I show, bomb in the eye, 6/6 N6. Luckily we had, in fact, after the macula there is no perfusion. The whole area is ischemic. So 6/6 vision. So written consent also, we did laser and everything, and ended up with surgery. Both eyes oil removal, and over many years he is maintaining some 660. So with good communication. And scene 5 is already there is a vitreous hemorrhage surgical case. Probably a medical retina specialist can give little laser and then refer to the surgeon for further management. Recurrent vitreous hemorrhage is another indication for vitrectomy. Especially once or twice you can wait 1 month, 2 months and give additional laser if possible. Otherwise it's an indication for surgery. Combined RD, absolutely no option other than surgery. Then TRD involving or threatening macula is theoretical indication. Yesterday also in one forum I said, actually this patient is maintaining vision for past 7-8 years with 6 by 18, 6 by 24. These sort of stable cases, we need not do a surgery. So in one one visit itself, don't decide all these things. And another thing is, I have 1 or 2 minutes extra. No problem. No? So another thing is, if a patient comes with one eye bleeding and the other eye has a PDR, you have to tell the other eye requires treatment, but don't give that priority because the patient has come for this eye. In fact, one of my colleagues gave right eye vitreous hemorrhage, left eye PDR. Right eye anyway we have to wait. By the time he started left eye surgery, left eye laser. 1 week later, patient came and told me, by mistake they gave laser in the other eye. I came for this eye. It's a communication problem. It is actually other eye also has PDR, but give priority. Talk to the patient and give priority. Which eye to treat is more important. So take home messages are, we need medical retina specialists in India to tackle diabetic retinopathy burden. Smart India program was there yesterday. The incidence and prevalence, everything, huge volume. It is millions in India, and we need medical retina people. But medical retina people should work in tandem with retinal surgeons, and they should understand their limitations, but they should do a good work. Now, unfortunately, in the last, with the advent of biosimilars, the rampant use of anti-VEGF has worsened the scenario. 20 years back, I used to get fresh PDRs like some of these nice PDRs. I treat with laser. If it worsens, I will do surgery. Now, all of them are coming with bad combined RD or late stage, advanced stage, because of irregularly and improperly managed diabetic retinopathy. So that is what we don't want. So, and finally, the last line, communication skill is the most essential quality in any practice. Biju was talking about yesterday about ethics and etiquettes and everything. After all, it is a teamwork. Thank you very much.
Thank you, Dr. Mahesh, for that excellent talk and the practical tips on how to proceed in different and difficult situations. Information from hardcore via surgeon was definitely beneficial.